Hi friends, happy World Breastfeeding Week. My name is Devastacia. I'm a board certified lactation consultant and I've been in the birth and lactation world for about 5 years now. Today I wanted to talk to you about a deep dive of commonly prescribed medications for postpartum depression or depression medications prescribed for postpartum people and their safety in lactation. So this is actually take two. I filmed this whole video and went to go edit it and there was no sound at all. So we're just gonna do it all over again. And hopefully it all works out and this is a useful video for you. So first I want to put up a little disclaimer here. I am a lactation consultant, but I am not your lactation consultant. Also, I am not a doctor. This is not medical advice. We are simply going to look at the most commonly prescribed depression medications and go through their safety, the different aspects that we look at to determine if a medication is safe during lactation, and just give you some basic information to discuss with your doctor or your healthcare provider and let you know that there is help available, and so you are empowered when you go to speak with your healthcare provider and you know what the different medications are available and how to assess these things on your own and where to find that information. Okay, so first we're going to start with what are the symptoms of postpartum depression, what kind of differentiates it from regular depression. Okay? So according to the Anxiety and Depression Association of America, or ADAA, in women with postpartum depression, symptoms usually begin within the first 4 weeks of giving birth, although some women report decreasing mood in the late third trimester of pregnancy. So also, if you experience depression or have a history of depression before pregnancy, you have a greater risk of having postpartum depression. In contrast to the postpartum baby blues, which affects 50 to 85% of women for a brief duration, usually 1 or 2 weeks after delivery, postpartum depression is associated with more severe and persistent symptoms that are present most of the day, nearly every day, for at least 2 weeks. At least 5 of the following symptoms are commonly present: sad mood, loss of interest or pleasure in things that you normally enjoy, fatigue or loss of energy, and of course you're going to be very tired. The first couple weeks postpartum are the most tired you'll ever be in your entire life because newborns are up constantly, you're worried about your baby, you're feeding all the time around the clock. It's the most tired you'll probably ever be in your life. But when you combine it with these other symptoms, that's when you want to, talk to your healthcare provider, or maybe, reach out to a counselor. Other symptoms include appetite increase or decrease, and your appetite may increase from lactation because you do require more calories to support lactation than you do to support pregnancy. So that is very common. Regardless of depression status. Sleeping too much or insomnia, feeling restless or as though you are slowed down, feelings of worthlessness or excessive guilt, difficulty concentrating or indecisiveness, thoughts of death or suicide or a suicide plan, anxiety and ruminating thoughts which may occur with other mood symptoms. So if you have any combination of these symptoms, definitely reach out to your healthcare provider or see if your insurance has access to a teledoc or telehealth line, so you don't even need to go out of your house to have an appointment. You can just do it in the comfort of your own home with your phone and just talk to a healthcare provider or a counselor or a therapist or whoever. Just someone to give you that support that you need, and you don't have to worry about packing up your baby and leaving your house. because I know that can be really, really hard, especially with so many appointments to juggle postpartum. The next article we're going to look at is called Pharmacotherapy of Postpartum Depression, an update by Dr. Deborah Kim, MD, et al. And in this article, she states that SSRIs, selective serotonin reuptake inhibitors, should be the first line of defense for postpartum depression once it's established that the person does not have bipolar disorder. So, the article states, postpartum depressive episodes do not present as substantially different from depressive episodes outside of the postpartum period, except that obsessions and ruminations focusing on the newborn and fitness for mothering are more common. Postpartum anxiety often presents in addition to depression, and when both conditions coexist, the presentation is often more severe. So, you might, if you are experienced with having depression before pregnancy, postpartum depression might feel similar, but your sad thoughts or your anxious thoughts are more focused on the safety of your baby, the health of your baby, and how well you are parenting your baby. So you might be not sleeping at all because you're staring at your baby because you're so afraid that they are not going to keep breathing or something like that. That is super common. That's a very common fear and a way that postpartum anxiety presents. Also, it might come out as anger or rage, and you might feel yourself either exploding at things, at the smallest little thing, or breaking down in tears. So those are all things to look out for. This also states that when both conditions, anxiety and depression, exist, the presentation is more severe. So it's definitely something to discuss with your doctor, to be aware of, to look out for it with your friends who are newly postpartum. In the largest U.S. postpartum depression screening study to date, 66% of the women with an Edinburgh postnatal depression scale score greater than or equal to 10. Sample had a comorbid diagnosis, most commonly anxiety. So the Edinburgh postnatal depression scale is a screening tool that we use. I have it in my intake forms for clients, and it's just a screening tool to assess the level of depression you may be experiencing. And 10 or more indicates a level of depression. So in their study, parents who indicated some level of depression, most commonly, if they had another diagnosis, most commonly it was anxiety. Postpartum depression is one of the strongest predictors of suicidal ideation in new mothers. So it's not something to take lightly. It is definitely something that can be serious and life-threatening. So if you're even slightly feeling like these symptoms might be postpartum depression, please reach out for help. You deserve to have support and joy and happiness, and you deserve to be able to reach your goals. And there are people and professionals available to help you reach those goals. So how do you find information about medications and their safety in lactation? A great resource is the Infant Risk Center. So here is their number. I'm going to leave that up there for a little bit. The Infant Risk Center is run by the same people who produce Hale's Medications and Mother's Milk. The website is Hale's Meds. I have the hard copy. I have a subscription to the website. I also have, the app, so I can easily look up this information for you. But there are also resources available, like anyone can buy this book. And it's a great resource, but it is, because it's a book, it's not updated as frequently as an app or a website or the center with the information that they have available. So what can you do besides call infant risk? If you want to just look up medications on your own, you can get the Mommy Meds app, and it is totally free. You can scan barcodes with it. You can type in the medication name, and it will tell you the safety for pregnancy and for lactation for different medications and supplements. And it is a great resource to have, especially if you have a cold or a sore throat or something, a headache, and you're in the store looking for things, and the back of the medication says ask a healthcare provider before taking if you are pregnant or breastfeeding. Go ahead and scan that barcode, type in the active ingredients, and see what they say. So you do all this. How do you know? How do you know what's safe? So the way that medications are classified for their safety in lactation is with a scale from L1 to L5. L1 is completely compatible with breastfeeding. Hale's Medication in Mother's Milk says this L1 is a drug that has been taken by a large number of breastfeeding mothers without any observed increase in adverse effects in the infant. Controlled studies in breastfeeding women fail to demonstrate a risk to the infant, and the possibility of harm to the breastfeeding infant is remote, or the product is not orally bioavailable to an infant. So L1, safest, totally cool to take during lactation. L5, however, is completely hazardous. So that is, studies in breastfeeding mothers have demonstrated that there is a significant and documented risk to the infant based on human experience, or it is a medication that has a high risk of causing significant damage to an infant. The risk of using the drug in breastfeeding women clearly outweighs any possible benefit from breastfeeding. The drug is contraindicated in women who are breastfeeding an infant. So it's a scale, and you want to, during lactation, aim for things that are in L3 or below, because L4 is potentially hazardous. All the drugs that we're going to talk about today are L2s, which is probably compatible. A drug that has been studied in limited number of breastfeeding women without an increase in adverse effects in the infant, and or the evidence of a demonstrated risk that is likely to follow use of this medication in a breastfeeding woman is remote. So every medication we're going to look at today is going to be an L2. So they are all safe for lactation, and any medication you have to weigh the risks and benefits. So if the benefits of providing breast milk to your child outweigh the risks of any possible risks of the medication passing through the breast milk to the baby, that those benefits must be higher than the risks, and those are things that you have to weigh with your doctor. So other things that we look at are the relative infant dose, which is how much of the medication passes through into the breast milk that the baby would then get by nursing or drinking express milk. We also look at, the relative infant dose should be less than 10%, and even better if it's less than 5%. So I will point those all out during the video. We're also going to look at the molecular weight. So medications that have a molecular weight of less than 500 more easily pass through breast milk. The closer they are to 200, the easier it is for them to pass into the breast milk. the greater the molecular weight, the harder it is for the medication to get into the breast milk. So I hope that makes sense. It's a vast simplification, but hopefully that makes sense, and it lets you know what you're looking at when you do look these medications up. We also look at the oral bioavailability. So that is how much of the medication is going to be absorbed for the baby after they have ingested it through the breast milk. So hopefully that makes sense. So one or all of these things should be low. If like oral bioavailability is high, then the relative infant dose should be very low in order for that to be a safer medication, because that means even though baby's going to be able to absorb this medication through ingesting it, they're not going to be ingesting very much. Hopefully that makes sense. Okay, so the most commonly prescribed antidepressants in postpartum women are SSRIs, or selective serotonin reuptake inhibitors. So we're going to take a look at a couple of those. So the first medication we're taking a look at is fluoxetine, which is an L2. Fluoxetine has been used in perhaps 1 million breastfeeding mothers over the past 2 decades. There have been some reports of mild complications, but they may actually be attributable to a discontinuation syndrome rather than toxicity from the medication. While sertraline and escitalopram levels in milk are probably lower, fluoxetine is quite suitable for breastfeeding mothers and their infants. Remember, the risk of untreated depression is far higher than the risks of this medication. Several case studies have suggested that premature infants who have had exposure to fluoxetine in utero may develop symptoms of toxicity after continued exposure through breast milk. Infants born of mothers receiving fluoxetine are born with full steady-state plasma levels of the medication, and each time they are breastfed, the level in the infant may rise further due to the medication's long half-life. So that last half is about people who took fluoxetine during pregnancy and not only postpartum. You can see that the usual dose given is 20 to 60 milligrams a day, and the relative infant dose is 1.6 to 14.6. So obviously it varies depending on what dosage of the medication you're getting, but baby is still getting very little of that, especially if you're having lower doses. So if you are concerned, your doctor prescribes you this medication, perhaps discuss with them sticking with a lower dosage to begin with to keep that relative infant dose below that 10%. It is 100% oral bioavailable, so baby does ingest that medication, and the half-life is 2 to 3 days, so it does stay in your system for a longer period of time. The molecular weight is 345, so it is a smaller molecule. It can get into breast milk, not super easily, but it's not the biggest molecule size, so it does pass through into the breast milk. Okay, so the next medications we're going to talk about are paroxetine and sertraline, and those two are preferred medications for use in lactating parents. First, we're going to talk about paroxetine. As you can see, it is also an L2. The Infant Risk app says paroxetine is a typical serotonin reuptake inhibitor. Levels in milk are quite low and average less than 2.8% of the maternal dose. Probably quite safe in breastfeeding mothers. If used during pregnancy, there are some concerns. So this is, again, something that you want to look at on your own, because I'm speaking directly about lactation risk today. I'm not going to go into the pregnancy concerns right now. The usual dose prescribed is 20 to 50 milligrams a day, and the relative infant dose for that is 1.2% to 2.8%. So it's super, super low. It is completely bioavailable, so baby is going to absorb that medication through the breast milk. However, such a little percent of the medication actually gets into the breast milk, and the half-life is 21 hours. So it stays in your system for a much shorter duration than fluoxetine. And the molecular weight is 329. So it's I think a little bit bigger. I don't know what I said the last one was. But I mean around the same size molecule. So because the relative infant dose is so much smaller, paroxetine is definitely favored over fluoxetine as far as safety and lactation goes. Let's take a look at sertraline now. So sertraline again, an L2. Limited data, probably compatible. Sertraline has been extensively studied in many breastfeeding mothers. The data is consistent that levels in milk are quite low. Sertraline is a preferred antidepressant in lactation. So you can see the usual dose is 50 to 200 milligrams a day, and the relative infant dose is 0.4% to 2.2%. So even if you are taking 200 milligrams of sertraline a day, very, very little of that is getting into the breast milk. The half-life is 26 hours, so it stays in your system longer, and it's completely orally bioavailable. And the molecular weight is 306. So that's a smaller molecule than the last two medications we looked at. But again, the relative infant dose is so very small that this is preferred to the other two. Okay. So the next medication we're going to look at is Venlafaxine. And Venlafaxine is not a normal SSRI. It is called an SNRI, which is a serotonin norepinephrine reuptake inhibitor. And it is an L2. Venlafaxine is a new serotonin reuptake inhibitor antidepressant. The clinical dose of venlafaxine transferred via milk is about 6.4% for both metabolite and parent drug. Thus far, no reports of adverse effects have been found following exposure via milk. However, recent data has suggested that infants exposed in utero may have adverse effects upon delivery. And you can see what those adverse effects are. They're listed on the screen. And those are for parents who were taking venlafaxine during pregnancy. And those symptoms might be due to a withdrawal syndrome as opposed to toxicity from the drug itself. You can see the usual dosage given is 75 to 225 milligrams a day extended release, and the half-life is only 5 hours, so it does not stay in your system very long. The oral bioavailability is 45%, so it's not going to be completely absorbed by the baby through lactation, through the breast milk. And the relative infant dose is 6.8% to 8.1%, so that's a little bit higher, but it is still below that 10% kind of cutoff for safety, and because it's not completely bioavailable, it's a little bit safer. You know, you kind of have to weigh those things and make that kind of trade-off and see how everything, stacks up. And the molecular weight is 313. So again, it is a smaller molecule. It does a little bit more get into the breast milk, but it's less easy for baby to absorb and process that. So you have lots of options as far as prescription medications that you can take at home for postpartum depression. Now, the FDA recently approved a new drug specifically for postpartum depression. All of these other medications that we have just discussed are basic antidepressants. They are not made specifically for postpartum depression, while this new drug is. This drug is called Zulresso. The generic name is brexanolone. So I'm going to take this down. I'm going to give you some info on brexanolone here. So first I want to kind of go through the FDA's press release, and I will link that also in the video if you want to read more about it. Let me get that here. Okay. So Zulresso is not something that you can be prescribed and go to the pharmacy and pick up. It is an IV treatment, so you have to be in a hospital to have this administered. So I'm going to just, read a little bit of this press release here. So this is a quote. Postpartum depression is a serious condition that, when severe, can be life-threatening. Women may experience thoughts about harming themselves or harming their child. Postpartum depression can also interfere with the maternal-infant bond. This approval marks the first time a drug has been specifically approved to treat postpartum depression, providing an important new treatment option, said Tiffany Farchione, MD, Acting Director of the Division of Psychiatry Products in the FDA's Center for Drug Evaluation and Research. She continues, because of concerns about serious risks, including excessive sedation or sudden loss of consciousness during administration, Zulresso has been approved with a Risk Evaluate and Mitigation Strategy, REMS, and is only available to patients through a restricted distribution program at certified healthcare facilities where the healthcare provider can carefully monitor the patient. Okay. Zulresso will only be available through a restricted program called the Zulresso REMS program that requires the drug be administered by a healthcare provider in a certified healthcare facility. The REMS requires that patients be enrolled in the program prior to administration of the drug. Zulresso is administered as a continuous IV infusion over a total of 60 hours or 2.5 days. Because of the risk of serious harm due to the sudden loss of consciousness, patients must be monitored for excessive sedation and sudden loss of consciousness and have continuous pulse oximetry monitoring, which monitors the oxygen levels in the blood. While receiving the infusion, patients must be accompanied during interactions with their child or children. And this is so if you are nursing your baby or pumping or just holding your baby while having this IV treatment, you have to have someone present with you in case you were to suddenly fall asleep or lose consciousness or pass out, so you don't drop the baby. And this is why it is not available for home use. The need for these steps is addressed in a boxed warning in the drug's prescribing information. Patients will be counseled on the risks of Zulresso treatment and instructed that they must be monitored for these effects at a healthcare facility for the entire 60 hours of infusion. Patients should not drive, operate machinery, or do other dangerous activities until feelings of sleepiness from the treatment have completely gone away. The efficacy of Zulresso was shown in 2 clinical studies in participants who received a 60-hour continuous IV infusion of Zulresso or placebo and were then followed for 4 weeks. One study included patients with severe postpartum depression, and other included patients with moderate postpartum depression. The primary measure in the study was the mean change from baseline in depressive symptoms as measured by a depression rating scale. In both placebo-controlled studies, Zulresso demonstrated superiority to placebo and improvement of depressive symptoms at the end of the first infusion. The improvement in depression was also observed at the end of the 30-day follow-up period. The most common adverse reactions reported by patients treated with Zulresso in clinical trials include sleepiness, dry mouth, loss of consciousness, and flushing. So, let's take a look now. So, Zulresso is also called brexanolone. That's the generic drug name. And it is an L2. Brexanolone is a unique antidepressant similar in structure to allopregnanolone. The manufacturer reports that data from a lactation study in 12 women who received IV doses of 90 milligrams per kilogram per hour for 60 hours, that levels of brexanolone transferred to breast milk was exceedingly low, with a relative infant dose of 1 to 2% of maternal dose. In addition, because brexanolone has low oral bioavailability, less than 5% in adults, infant exposure is expected to be low. Concentrations of brexanolone in breast milk were at low levels, less than 10 ng per milliliter in more than 95% of women by 36 hours at the end of the infusion. Adverse events in breastfeeding infants are not expected. So you can see brexanolone looks like a great option. Relative infant dose is 1 to 2%, and half-life is only 9 hours, and oral bioavailability is less than 5%, so that is the lowest of all the drugs that we've looked at. The only issue here is that in order to have this treatment, you have to be in a hospital for 2.5 days hooked up to an IV and have someone able to bring your child to you to nurse, or you have to be able to pump continuously through your stay, and it's not very accessible. So this gives me hope. This is the first FDA approved drug specifically to treat postpartum depression. So I'm hoping that this means we are moving toward more treatments, better treatments, more accessible treatments for parents dealing with postpartum depression. So let me take this down again. So I hope this was helpful to you. Again, I would like to reiterate, this is not medical advice. This is just educational and hopefully empowering for you to have these skills and know what to look for, so that you can speak with your doctor in an educated way, so you can assess medications on your own and make those decisions. If you are uncomfortable with making those decisions on your own, of course, call the Infant Risk Center. I put the number up here again. And you can download that Mommy Meds app. You can speak to a pharmacist at your local pharmacy. Ask them to look it up. Call your local lactation consultants and see if they can help you. Your local WIC office should be able to look these things up for you. So you have a ton of options. Sometimes doctors don't have the most up-to-date information, or they just err on the side of caution, maybe a little bit too cautiously, and tell you to pump and dump during taking a certain medication, or say that you have to stop breastfeeding or something like that. So always be skeptical. Do your own research and ask for a second opinion. If it turns out that the medication actually is not safe for lactation, ask if there is an alternative that is just as effective. If you do need to cease lactation for a certain period of time, reach out to a lactation consultant and try to make a plan so that you can still reach your breastfeeding goals after that treatment is over. There are a lot of possibilities. There are a lot of ways to make a plan that works for you and your family. And if you are experiencing any symptoms of depression or anxiety, please, please, please talk to someone. Reach out for help. Postpartum Support International is an amazing resource, and I will link them below. They have a new text line, so you can reach out for support without having to say the words out loud, without having to call your doctor, without anyone hearing you talk about these things that might be really, really hard to talk about. I know I was so anxious with my first that I kept a log for more than the first year of his life of every time he nursed, on which side, how many minutes per side, every bottle he took, how many ounces, how much I pumped and how many ounces. when he napped, every diaper, every wet and poopy diaper. I wrote them all down, and the times. When he started eating food, I wrote down what he ate at every meal and about how much. And I did this, and I had the daycare's provider do it, and I had notebooks on notebooks of every single thing that went in or came out of his body for the whole first year of his life, because I was so afraid that something was going to happen, or I don't know, I just felt like I needed to know all of it. And no one was like, hey, this is a little excessive. No one said that you might have postpartum anxiety or postpartum depression. No one said those things to me. And it doesn't just magically go away. It can come out in different ways that don't seem like depression or don't seem like anxiety. They might seem like anger or rage or irritability. You might spill your coffee and just snap and start screaming or crying, and if that's happening to you or that's happening to your friends, please talk to them, talk to someone, reach out for help. Like, this doesn't have to be your normal. You don't have to feel like this, and you deserve joy with your baby and with your life and your new life of being a parent to this new little person. It doesn't have to be so hard, and you can get help. There is help available. Talk to your healthcare providers, your midwife, your friends, your doula. Get a postpartum doula to help kind of alleviate some of the tasks that might be building up for you. There's all this support and help available, and I hope this was helpful information for you. I'm going to link these articles below, all the ones that I have referenced. I will link the Anxiety and Depression Association of America below. I'll link Mommy Meds and Postpartum Support International. So you have all of the information available, all of the support that I can give you through a video. So you have all these resources at your fingertips. Because I know it's not always easy to find. And maybe you don't want things coming up on your search bar that might alarm your family. So I'll just give you the links. It's cool. But also, you don't have to be ashamed or embarrassed to have these struggles. It's super common. And I'm here for you. If you can relate to this, or if this was helpful for you, I would appreciate any comments. I would love to hear about your story. I would appreciate it if you gave it a like, if it was helpful. Share with your friends who might be pregnant or newly postpartum, and even if you're not concerned about them, just so that they have this information, because it's more than just about depression. This also has information on how to find out what meds are safe. So it's, I hope it's useful. I hope it's informative, and if you'd like to see more videos like this from me, hit the subscribe button so you get notified, and I appreciate you watching this far. Alright, I will be continuing, more videos all throughout this month, and continuing, it's Breastfeeding Awareness Month, or we'd call it BAM and WIC. I think it's National Breastfeeding Month or something, and also World Breastfeeding Week, and I hope that you are doing an amazing job. I hope you're having a great day. You are a great parent. You are enough just as you are, and I want you to remember that. Alright? Have a great day. Thanks for watching. Bye.